Honored to be here. Great meeting, great venue. Milan has been, I think, terrific for all of us. So I come from Charlotte, North Carolina, joined ERAS. I think a little background, my interest, like many people, necessity is the mother of invention. So I was happy doing congenital cardiac surgery, that sort of thing, and a car accident changed my life. I was out for about 18 months and then went back and did a critical care fellowship, and a few years later went back to business school as well, and that's when I really got involved in perioperative care and quality, that sort of thing. So glad to be here. I don't know if we'll call them conflicts, but things that I'm involved with that should mention. Grant from the Duke Endowment, and I do independent consulting for Medtronic. These numbers will be largely U.S. numbers and STS related, but cardiac care is common. In the STS database, 2015, there were about 152,000 coronaries and 600,000 cardiac surgical procedures. It's risky. Again, STS data, combined mortality, morbidities in the area, 12.2, 12.3% mortality, 2.2 with coronaries. And I mentioned things like the length of stay, readmission rate, all of which I think we have considerable opportunity. And it's very expensive in the United States, depending on what you read, but this is one good number. Coronary average is about $73,500 per case. This is a great slide that IBM did a study with 480 economists, 2010, and asked them to estimate waste in healthcare, and it's estimated to be $4.3 trillion a year in the world. And I don't know about you, but we certainly complain a lot about government, and you can see how much more efficient government is than healthcare. So again, I think whether you're looking at the quality or the resources, there's enormous opportunity for us to improve. So my time in Charlotte starts in 2004, and you can see where we were in 2003 with this one example of renal failure. This was the STS definition at the time, and it was about 3 times higher than the national average. We convened multidisciplinary team, and then I mentioned teaming, and that is the verb bringing people together and working on things. How we would communicate, and then some focus that I thought were important: early extubation, goal-directed therapy, glycemic control, blood management. And you can see where we went over about a 10, 12-year period to where in 2014 through July 2016, so 30 months, we had 492 coronaries with 3 cases of renal failure, 0.6%. 2014, we had 0. And I also include, so it doesn't appear sleight of hand, like we did great in one thing, but not the others, are operative mortality, major morbidity, prolonged ventilation, length of stay, readmission, so forth, to show that I think we were doing very good work in all of those areas. When you would quantitate this, and I use the Virginia Collaborative group's estimate for renal failure and then imputed the potential savings, it was about 1.3 million US dollars per year from where we were to what it looked like. And that's at $49,100 a case. Back in 2008, we published in JTCVS and showed that our risk-adjusted outcomes had improved by 40% with respect to mortality. And with respect to morbidities, we had an 80% decrease in tamponade, 50% decrease in sepsis, and 30% in renal failure. At the time that we published the renal failure, it wasn't significant, but it was right at the cusp. So then on to enhanced recovery, which in many ways mirrors work we do, the various phases of care, as you've heard, prehab, pre-op. Probably we emphasize certainly the operative care. Many of the things like Dan mentioned of cardiopulmonary bypass and blood management and goal-directed therapy in the operating room. I have to say we've probably been not as good about glucose control. That remains an area in the operating room that's been somewhat controversial. With a new set of anesthesiologists, that might change. Post-ICU care and post-acute care. on this, but in alphabetical order, the different areas that we've been focused on. As Dan mentioned, we've divided up these topics. I particularly had interest in early extubation, goal-directed therapy, AKI, and we'll just highlight those. So what we've said is early extubation strategies after cardiac surgery are reasonable to be employed. It's a class 2A moderate recommendation, and level of evidence is BNR, or non-randomized. It's been associated with improved outcomes after cardiac surgery, which includes decreased rates of mortality, morbidity, and decreased use of hospital resources. We also published on that in that same era is the early quality improvement program efforts. Goal-directed therapy should be performed to reduce postoperative complications. It's a class 1 or strong recommendation. It's a level BR, level of evidence, i.e. it's been randomized studies. And we think goal-directed in therapy and cardiac critical care consistently demonstrates reduced complication rates and length of stay. I would be the first to say, though, that optimal goals, their means, rate of achievement, for example, oxygen debt repayment schedule, their interactions, and the potential to mitigate specific complications such as AKI requires further investigation. With respect to AKI, we believe that it can be beneficial in identifying patients for risk for AKI. It's a class 2 recommendation with level BR randomized studies. And again, like the others we mentioned, goal-directed therapy in cardiac critical care consistently demonstrates reduced complications, rate of complications, and length of stay. And here, I'll highlight the work that Judson Williams, who couldn't be here, and Dan have done. As Dan mentioned, this will be published in JTCVS. Much like these other efforts, the various phases of care and mirroring what was seen in, say, gastrointestinal surgery, but specifically, they looked at sort of the pre-study phase and preparing for it, and then the post-study phase showed that narcotic use in the first 24 hours was reduced by 40%. Length of stay was reduced. Gastrointestinal complications were reduced by 50%. And then the more subjective things like patient focus and culture and engagement, it also improved in that phase. Dan can probably address some of the questions that you have afterwards, but I guess being one of the older ones in Louis, I'll define older for anybody that has questions later. We can reflect back some of the things that I think I've learned. Teamwork makes the dream work. My wife constantly reminds me of that. Keep score in the United States through the STS. We have a 1, 2, and 3-star system, 1-star a negative deviant, 2 average, 3-star positive deviation, and we've been quite successful. I want to say it was something like 9 of, what would have been, I take that back, it was 6 or 7 out of 12 episodes every 6 months that we get the star rating system, that we got 3 stars, and with our other programs, we've been able to replicate that. I think it's incredibly important. People innately, I think, have a competitive streak, and if you can find something like this to motivate them, it's useful. We focused, quite frankly, on aggregating data, analyzing it, and feeding it back to the team, and early on, we started to use cumulative sum charts. We're not the ones that discovered this. I certainly read about it in our literature, but it's something that we have every 2 weeks for the team so that our results are as close to real time and risk adjusted as possible to see where we stand, and it helps us, I think, learn quickly. We focused on continuous improvement. I mentioned a couple of those articles that we published. When you put the team's name on it and you highlight these things, there's this telling the world about an upward spiral of success. And I think most recently, and I show this as just an example, highlighting the grant that we got from the Duke Endowment that sort of catalyzes that ongoing work. And it's really been a great journey. I thank you for your time and look forward to answering questions at the end.
Thank you, Ken. I should call him. Yeah.